During the course of your career as an RN, you'll come in contact with many individuals who experience chronic back pain. There are many etiologies for chronic back pain. Some include degenerative disc disease, prior injury to the vertebral column, obesity, structural and postural defects, as well as systemic diseases. Today we'd like to talk about spinal stenosis, which is a bony overgrowth of the joints of the vertebrae, which leads to a narrowing of the spinal canal and compression of the nerve roots. Frequently, spinal stenosis is a result of the degenerative changes of the spine that occur from a disease process, for example, like osteoarthritis. This spinal stenosis results in functional limitations and chronic back pain. The degeneration of the joints and the discs of the spine are progressive and result in weakness as well to the lower extremities. Very frequently, the pain from spinal stenosis, which typically occurs in the lumbar regions of the spine, will radiate and be expressed as a burning and numbness in the lower extremities and buttocks. Surgery is commonly performed, and it may be indicated for severe pain and disability that's not responsive to more conservative measures. Another form of treatment could include epidural corticosteroid injections, as well as implanted devices that deliver pain medications on an ongoing basis. Less dramatic interventions include the use of NSAIDs and analgesics, which are used to relieve pain and stiffness, hot and cold therapy, massage therapy, acupuncture, and don't forget about the importance of weight reduction in helping reduce some of the pain and functional limitations associated with this problem. Also, exercise is important because it keeps the muscles and the joints mobilized so that the individual can engage in regular activities of daily living. During the course of your career as a registered nurse, you're going to be caring for many individuals with some sort of chronic back pain. There are many etiologies of this back pain. Some of them include degenerative disc disease, prior injury to the spinal cord or vertebral column, obesity, structural and postural changes and defects, as well as systemic diseases. Today we'd like to talk a little bit about spinal stenosis, which is an overgrowth of the joints of the vertebrae that leads to a narrowing of the spinal canal and probable compression of nerve roots. Frequently, spinal stenosis can be a result of trauma or degenerative changes of the spine, such as osteoarthritis. And that is the most common cause, the degenerative changes of the spine, such as arthritis. Intervertebral degenerative disc disease is a term that encompasses several structural changes to the intervertebral discs. Spinal stenosis is one form of degenerative disc disease. Degenerative disc disease is the structural degeneration of the lumbar and cervical discs. It is a progressive problem and it's considered a normal part of aging. What happens is the discs lose their elasticity, their flexibility, and their ability to absorb shock. What happens is the gelatinous center of the disc dries out and shrinks. You can see this indicated on the diagram in this slide. The top disc is a normal disc, and you can see how the degenerated disc below it is flatter and less dense and less able to absorb the shock. It also can end up resulting in osteoarthritis of the spine when the bone from one vertebrae rubs and has contact against the other bone, which obviously will result in increased pain. Another form of degenerative disc disease is the herniated intervertebral disc. This is also referred to as a slipped disc. Two possible causes for that include natural degeneration of the disc with age, or repeated stress and trauma to the spine, or a combination of both. What happens is the disc actually protrudes into the vertebral column and places pressure on the nearby nerves, which results in low back pain. The most common sites for herniated discs include the lumbosacral discs, and it also can be a result of spinal stenosis, where the narrowing of the spinal canal creates the bulging of the intervertebral disc. You can see it indicated on this slide in the lower right-hand corner. If you notice where the line is pointing to the herniated disc itself, there's also a good image of this on the previous slide. Patients with herniated discs typically report claudication-like symptoms of burning, paresthesia, or muscle weakness in the legs, feet, and toes. It's important for patients to realize that when these symptoms are present, they need to report the symptoms to their healthcare provider. Multiple nerve root compression due to a herniated disc can be manifested also as bowel and bladder incontinence or even impotence, and these issues may in fact constitute a medical emergency. So, radicular pain that radiates down the buttock and below the knee along the sciatic nerve is often an indicator of disc herniation, and the RN needs to be sure to educate their patients to report these types of symptoms to the healthcare provider. The cause of ankylosing spondylitis is unknown, but genetic predisposition appears to play an important role in the disease pathogenesis. Although the usual age of onset is early, between 15 and 35 years of age, the highest incidence of the disease is in people between the ages of 25 to 34. Men are more likely than women to develop ankylosing spondylitis, and often the disease actually goes undetected in women because it often follows a milder course, and it's not typically considered in a differential diagnosis for the female population. Ankylosing spondylitis results in severe postural abnormalities and deformities that can lead to a significant disability for the patient. This impaired spinal range of motion and fixed kyphosis as a result of the fusion together of the vertebrae that are involved contributes to altered visual function, raising concerns for safe ambulation. Aortic insufficiency and pulmonary fibrosis are frequent complications of this disorder. As far as diagnosing ankylosing spondylitis, x-rays are essential. However, they're not typically used in the initial diagnosis phase. Instead, pelvic x-rays are used because they demonstrate characteristic changes of sacroiliitis that range from subtle erosion to completely fused joints in which the joint spaces have been obliterated. When the suspicion of ankylosing spondylitis is high, the presence of the HLA-B27 antigen, this genetic component, improves the likelihood of this diagnosis. Prevention of ankylosing spondylitis is not possible. Instead, collaborative management includes early detection and treatment. Home management should include attention to regular exercise and posture and the use of local moist heat as well as drug therapy. Exercise should include stretching and strengthening exercises. Prolonged standing and walking should absolutely be avoided. Proper positioning at rest is very essential. A firm mattress. Individuals should sleep on their back and avoid positions that encourage flexion deformity. Deep breathing exercises that encourage chest expansion will decrease the risk of pulmonary complications, and smokers should certainly be encouraged to stop. Pharmacological interventions include the use of DMARDs, or disease-modifying anti-rheumatic drugs, Enbrel, which inhibits the inflammatory response, as well as NSAIDs. Also useful in this disease process are local corticosteroid injections and even hydrotherapy. The surgery that's performed on ankylosing spondylitis includes a spinal osteotomy, and total joint replacement are the most common forms. Lyme disease. It's an infection caused by an organism called Borrelia burgdorferi, which is transmitted by the bite of an infected deer tick. It was identified in Lyme, Connecticut, after an unusual clustering of arthritis developed in a certain group of children. It's now the most common vector-borne disease in the United States. The tick involved in Lyme disease feeds on domestic animals such as cats, dogs, cows, perhaps deer, and humans. It is not manifested in wild animals, and there is no person-to-person transmission. Summer is considered the peak season, and there are 3 areas in the United States where it's most common. That would be in the Northeast, from Maryland to Massachusetts, certain parts of the Midwest, and California and Oregon in the Northwest. Left untreated, Lyme disease will spread within several weeks or months to include the heart, the joints, and the central nervous system. Lyme disease symptoms can mimic other diseases, for example, multiple sclerosis, mononucleosis, and meningitis. The most characteristic and useful diagnostic symptom of early localized disease is erythema migrans, which is a skin lesion that frequently occurs at the site of the tick bite within 2 to 30 days after exposure. The lesion, erythema migrans, begins as a red macule or papule that slowly expands to form a large round lesion with a bright red border and central clearing. This lesion is often accompanied by acute viral-like symptoms including a fever, chills, headache, stiff neck, fatigue, and swollen lymph nodes. Symptoms usually occur in a week or within a week, but may be delayed for up to 30 days after being infected by this infected tick. A diagnosis of Lyme disease is often based on clinical manifestations, in particular the erythema migrans lesion, as well as a history of exposure in the endemic areas that I mentioned. To confirm the diagnosis of Lyme disease, a two-step lab process is recommended. The first step involves an ELISA test, and the second test, if the ELISA test is positive, the Western blot test should be done. And if both of those are positive, the indication of Lyme disease is fairly accurate. Active lesions involved with Lyme disease can be treated using oral antibiotics. Doxycycline, cefuroxime, and amoxicillin are very effective in treating early-stage infection, as well as in preventing later stages of the disease. Doxycycline is even effective in preventing Lyme disease if it's given within 3 days after the bite of an infected deer tick. There is no vaccine available for treating or preventing, I should say, Lyme disease, and reducing exposure to ticks is actually the best way to prevent it. We also want to educate our patients on how important it is to use insect repellent during the summer months. Moving on to systemic lupus erythematosus, or SLE. Systemic lupus erythematosus is a multisystem inflammatory autoimmune disease. It's a very complex disorder of multifactorial origins, resulting from the interactions of genetic, hormonal, environmental, and immunologic factors. Systemic lupus typically affects the skin, the joints, serous membranes, along with renal, hematologic, and neurologic systems. Women are 10 times more likely to develop systemic lupus than men, and the women are usually in their childbearing years. There's also an ethnic component as African Americans, especially, as well as Asian Americans, Hispanics, and Native Americans are more likely than Caucasians to develop the disease. It's characterized by variability within and among people. Its chronic, unpredictable course is marked by alternating periods of exacerbations and remissions. The exact etiology of the abnormal immune response in systemic lupus is really unknown, but we do believe that there is a genetic component because of the high prevalence of systemic lupus among family members. We know that hormones also play a role in the etiology of lupus. The onset or exacerbation of disease symptoms can sometimes occur right after the onset of menarche with the use of oral contraceptives and during and after pregnancy. The disease actually can tend to worsen immediately postpartum. We know that there's also environmental factors that are believed to contribute to the occurrence of lupus, especially with sun exposure and sunburn being the most common environmental triggers. Systemic lupus is characterized by the production of a large variety of autoantibodies. Again, it's an autoimmune disease against the nucleic acids, erythrocytes, coagulation proteins, lymphocytes, platelets, and many other self-proteins. These autoimmune reactions are characteristically directed against the constituents of the nucleus, particularly DNA. So again, hormones are known to play a role in the etiology of systemic lupus. Out of the environmental factors that are involved, we know that exposure to sun and sunburns are the most common environmental triggers, and there are certain medications that also can precipitate or aggravate systemic lupus, and those include Pronestil, apresilene, and certain anti-seizure medications. Lupus, systemic lupus, is very variable in its severity. It can range from a very relatively mild disorder to, again, a rapidly progressive one that affects many body systems. This image here shows you the classic butterfly rash, very common and characteristic of systemic lupus. This rash spreads over the cheek and the bridge of the nose, and it's present in approximately 50% of the patients with systemic lupus. Here are some more images of individuals with systemic lupus lesions. These cutaneous vascular lesions apparently can appear in any location, but they're more likely to develop in areas that are exposed to the sun. There's no characteristic pattern in the progression of systemic lupus. Any organ can be affected. However, the most commonly affected tissues are those of the skin and the muscles, the lining of the lungs, the heart, the nervous tissue, and the kidneys. Generalized complaints such as fever, weight loss, and excessive fatigue may actually precede an exacerbation of the disease activity. So individuals with this disease very often manifest some generalized complaints before they are experiencing an exacerbation. The diagnostic criteria for systemic lupus are listed in Table 65-14 in your Lewis text. I will not test you specifically on those criteria, but I would ask that you take a look at them. Those symptoms will become apparent through the obtaining of a patient history and a physical exam. Two tests that are used commonly to confirm systemic lupus include the anti-double-stranded DNA test. High levels of anti-DNA are rarely found in any other condition other than systemic lupus, and the anti-Smith test, which seems to be found almost exclusively in systemic lupus erythematosus patients. Pharmacological interventions include NSAIDs, and antimalarial agents. For those with severe cases of systemic lupus, high doses of corticosteroids and immunosuppressant drugs are indicated. Prevention of this disease is not possible, so we want to provide early detection measures as well as treatment. Emotional support for our systemic lupus patients is very important as these patients are confronted with many psychosocial issues. Counseling the patient and the caregiver that systemic lupus has a good prognosis for the majority of people is important, and providing counseling to families who are anxious about the hereditary aspects is very important for couples of childbearing age. The obvious physical effects of skin lesions and alopecia may cause the patient with SLE or systemic lupus to have problems with self-esteem and body image. There may be an appropriate dermatological consultation for these problems. However, patients typically report pain and fatigue as the most often, as those symptoms that most often interfere with the quality of their life. So pain and fatigue. We want to be sure to teach our patients the importance of using sunscreen, as we know that severe skin reactions can occur in patients with systemic lupus who are exposed to the skin. So sunscreen, as well as covering up their, most of their body with clothing when out in the sun. We want to teach our patients to avoid fatigue and to take periods of rest as necessary. And we also know that oral contraceptives can exacerbate systemic lupus, so discussing perhaps other alternative methods of contraception would be something we would offer to our patients as well. Fibromyalgia syndrome is the last disorder that I'm going to talk about today. Fibromyalgia is known to be non-degenerative, non-progressive, and non-inflammatory. It is, however, a chronic disorder that's characterized by widespread non-joint musculoskeletal pain and fatigue with multiple tender points. People with fibromyalgia syndrome typically experience sleep that's not restorative, morning stiffness, irritable bowel syndrome, as well as anxiety. Patients with fibromyalgia typically complain of a widespread burning pain that worsens and improves through the course of a day. And it's very difficult sometimes for these patients to discern whether or not the pain is in the muscles, in the joints, or the tissues. Cognitive effects of fibromyalgia syndrome include, they can range from difficulty concentrating to memory lapses and a feeling of being overwhelmed when dealing with multiple tasks. Many individuals actually report migraine headaches, and depression and anxiety often occur and may require pharmacological interventions. Restless leg syndrome is also a common coexisting disorder along with fibromyalgia syndrome, and paresthesias of the hands and feet are common as well. This syndrome is 6 times more common in women than men, and it affects approximately 2 to 5% of the population. This image shows you the multiple tender points that are useful in diagnosing fibromyalgia. Physical exam typically reveals tender points at 11 or more of 18 identified sites, and that is very useful in diagnosing fibromyalgia because a definitive diagnosis of this disease is often very difficult to establish. Actually, the American College of Rheumatology classifies an individual as having fibromyalgia syndrome if 2 criteria are met. 1, pain is experienced in at least 11 of the 8 indicated tender points on palpation, and 2, there is a history of widespread pain that's noted for at least 3 months. This widespread pain also needs to be defined as occurring on both sides of the body and above and below the waist. So that's diagnostic criteria for fibromyalgia syndrome. Pharmacological intervention for fibromyalgia syndrome include targeting problems with pain, as well as medications that may have sedative effects that can actually help improve the nighttime rest for the patients with this fibromyalgia syndrome. Very often depression accompanies this disease, and some antidepressants will actually have a sedative effect that can serve to help patients improve their restorative nighttime rest. Because of the chronic nature of fibromyalgia, the patient is in need of consistent support from the nurse and other healthcare team members. Relaxation strategies are important to help these individuals deal with the chronic stress that's typically involved. Dietitians are typically urge fibromyalgia patients to limit their consumption of sugar, caffeine, and alcohol, since these are substances that have been shown to be muscle irritants and may in fact contribute to some of the pain that these individuals experience. Patients also need to receive teaching and relaxation strategies that they can continue to practice in their own homes. The very last thing I'll talk about today, and I'm sure you're all excited to hear me finishing up this presentation, are foot problems. And that's because they're typically overlooked in our assessments and in our plans of care for our older adults. However, foot problems, especially pain, is very common in our older adult population. With aging, our feet show natural signs of wear and tear. The cushioning layer of the fat on the soles of the feet becomes thin, and that causes the bones to spread and the ligaments to stretch, resulting in pain. We can have the formation of corns and calluses, Arthritis and other age-related changes can predispose older adults to bunions, which are bony protuberances on the sides of the great toe, which results in bursitis and pain. The older adults also develop many nail disorders that require treatment with antifungals and require attention over several months. Very often, our older adults may have impaired range of motion, and it's difficult for them to get down and clip their own nails. It's difficult for them to provide themselves with good foot hygiene. So, when you're working with your older adult population, pay attention to their feet and ask them if they have difficulty walking. If they see a podiatrist on a regular basis, and provide them with resources and recommendations that are appropriate for your particular patient and their situation. This concludes my presentation. As always, please address any specific questions to me. I do use the Lewis text as a primary resource for most of this MedSurg content, so further elaboration of any of these disease processes that I've spoken about today can be found within that resource.